dramatically improve patient outcome. The goal of the pericardial window is to detect the presence of hemopericardium. So in order to master this window, you need to know what blood looks like and where it's going to be located. At the completion of this module, you should be able to look at this subcostal window, determine if a pericardial effusion is present, and in addition, determine if any other free fluid collections are present. Let's take a look at these two examples here, because basically you're going to be using your knowledge of colors and shapes in order to determine where the red fluid is located. You can see here that there's a round container, a rectangular container, and a triangular container. Here you have the same thing. You have a rectangular container, a round container, and a triangular container. If I asked you where the red fluid is located, here you're going to recognize that here is the red fluid, and you're going to look at the outline and the shape of it and notice that this is triangular, so you would then be able to reason that the fluid is present here in the triangular container. Now looking over here, you'd be able to identify, based on your knowledge of colors, that here is the red fluid, and looking at the outline of it, you'd be able to say that this fluid is contained within the rectangular container. This is the same type of reasoning you're going to use when you look within the chest or in the abdomen for the presence of free fluid versus contained fluid. So remember, fluid is going to be formless and shapeless. It's going to have to take the shape of the container that it's in. Now, hemopericardium is going to be easier to isolate than hemoperitoneum. Here you've got a CAT scan of the chest in a patient with a large pericardial effusion. You can see that the pericardial effusion is going to be between the parietal and visceral layers of the pericardium, and it's going to outline the heart. So it should be relatively easy to identify a pericardial effusion. You just have to identify the heart, and you have to make sure that this fits the shape of the container. Now, it's possible with smaller fluid collections that they could be localized, but again, you're going to have to follow the boundaries of the heart and make sure that this fluid collection is indeed within the pericardium. Okay, so you know where the pericardial fluid collection is going to be located. What is it going to look like? Now, depending on how much clotting has occurred, that's going to be the big difference in how the fluid collection will appear. If you look here on the right, you've got an anechoic fluid collection, meaning that it is devoid of echoes and it is black. Here you've got a patient who has an echogenic fluid collection. Now in the textbooks, they describe it as being a relatively straightforward process, that acute hemorrhage will be anechoic, and then over the ensuing next 2 days, as clotting occurs, you will get an echogenic appearance, and then as the blood resorbs over the ensuing 2 weeks, you'll eventually get back to an anechoic appearance. However, in somebody who bleeds very rapidly, clotting may occur very quickly, and you may find an echogenic effusion right from the start. So it's important to recognize that fluid may be anechoic or it may be echogenic. A big reason for missing even relatively large fluid collections is that in your mind, you're only looking for something black, and it's very easy then to look past a echogenic fluid collection. So remember, fluid, even in the acute state, or hemorrhage, even in the acute state, can be echogenic, and we'll show you numerous examples within this module of patients who came in with an acute traumatic injury and were found to have echogenic fluid collections. Here's another example just to reiterate the point. This is a subcostal window, and we'll go over that in future lectures. But you can see here, surrounding the heart within the pericardial sac, here you've got the parietal, here you've got the visceral layers of the pericardium, is a very large echogenic fluid collection. This was a patient who was stabbed in the chest approximately 15 minutes prior to arriving in the emergency department. So just keep in mind that you have to look for either an anechoic or an echogenic fluid collection. Since the echogenic appearance of this fluid collection is relatively similar to the surrounding tissue, on a quick glance, it would be very easy to miss this. So just keep that in mind as we go through the modules. This concludes the Search for Hemopericardium video. I'm Dr. Robert Jones, and in this lecture we're going to go over how to perform the subcostal window. Looking at the subcostal anatomy, you can see that if the transducer is held up here in the subxiphoid space, you're going to have to go through the liver as a window in order to get into the chest and obtain a four-chamber view of the heart. Here you can see if the transducer is here in the subxiphoid space, you're going to be angling in using the liver as a window into the left hemithorax in order to obtain the four-chamber view of the heart. It's also important to note that even in a relatively thin patient, you're going to have a very large field of depth in order to be able to get all the way into the chest here and visualize the entire heart. So here we have a subcostal window. The transducer is held on the top. You do not want to have your hand underneath the transducer, since that's going to require you to bury your fist into the abdominal wall, which most patients with blunt or penetrating thoracic and abdominal trauma won't tolerate. So you're going to hold the transducer, you're going to angle it under the xiphoid process into the chest. The indicator is going to be directed towards the patient's right. The image you're going to get is as follows. This is a transducer, anterior and inferior on the abdominal wall. You're angling posterior and superior into the chest. So this is going to be patient's right, patient's left. Here's the liver as a window. Here is going to be the right atrium, right ventricle, and left atrium. Let's first look at scanning essentials. Which transducer are you going to use? The bottom line here is you can use any of these three transducers. The decision on which transducer to use is going to be based on the frequency and then the footprint of the transducer. All of these transducers are in the range of about 1 to 5 megahertz, so this will give you adequate penetration into the adult torso to visualize the heart. The real difference here is in the footprints of the transducers. Since in the FAST exam you've got 2 intercostal windows and 1 subcostal window, I think you're better off using a transducer with a smaller footprint. So while all 3 of these could be used, if I had to choose, I would pick either the small footprinted curvilinear or the phased array transducer. Let's look at some subcostal images obtained with the various transducers. Here you have a large footprint curvilinear transducer. You can see the approximate 4 centimeter footprint here. You can see that with this transducer, you're still able to obtain a nice 4-chamber view of the heart. Here we have a subcostal window in a patient where the small footprint curvilinear transducer was used. You can see here's the small footprint. And you can see that there's a wide sector image here. And this was a patient that had a large echogenic pericardial fluid collection. But again, you are able to obtain a nice subcostal image with this transducer. Lastly, you have a subcostal image obtained with a phased array transducer. Note again the wide sector image here. You can see the liver being used as a window, and here's your 4-chamber view of the heart. So this one provides a very nice subcostal image. Now you have a choice of image presets. You can either use the abdominal mode or the cardiac mode. Since the FAST exam has 3 abdominal windows and 1 cardiac window, I would recommend just sticking with the abdominal mode. Now there may be some difference in terms of the preset between abdominal mode and cardiac mode, since the cardiac mode is designed for looking at moving structures. But for ease of performance, I would recommend sticking with the abdominal mode throughout. A lot of machines, when you're in the abdominal mode, boot up with about 15 centimeters of depth. You really want to make sure that you increase that field of depth to about 22 centimeters, because even in a thin adult, you're going to need a wide field of depth in order to visualize the entire heart. Here's an example of why correctly setting image depth is important. Here was how the depth was set with the preset, and you can see that you're just barely seeing the right side of the heart in this patient, so you're going to want to increase your field of depth. From a patient positioning standpoint, this exam is usually performed with the patient in the supine position. From a scanning checklist standpoint, make sure that you have an adequate amount of gel. Make sure you've got the correct transducer. Make sure you're set to the abdominal mode. If you're in the abdominal preset, the indicator is going to go towards the patient's right. If you're in the cardiac preset, in order to obtain the standard image orientation, you're going to place the indicator towards the patient's left. And make sure that you have at least 20 centimeters of depth in order to adequately visualize the heart. Also make sure that you're grabbing the transducer with your hand on top of the transducer so you do not have to bury your fist into the abdominal wall. Let's look at the exam in a step-by-step fashion. In step 1 of the exam, you're going to begin by placing the transducer in a straight anterior-posterior position, indicator towards the patient's right. This will give you the following image: anterior, posterior, patient's right, patient's left. You're using the liver as a window, and you're going to be following the inferior vena cava as it enters the heart. In future modules, we'll go through why it's important to follow and to visualize the inferior vena cava, since this can provide you with information regarding central venous pressure, as well as in determining fluid responsiveness. In step 2, angle the transducer, continuing to follow the inferior vena cava as it enters into the chest. So here again, you're still using the liver as a window. Here you can see the hepatic veins draining into the inferior vena cava. You're not yet seeing the heart, but you're just continuing to angle the transducer into the chest. Next, you're going to identify the right atrial caval junction, because it's at this point that you should start to be able to visualize the heart. And you're going to get to this point by continuing to angle into the chest. The transducer is still directed towards the patient's right. All you're doing is flattening your hand out and angling into the chest, following the inferior vena cava. In the last step, here's where you should be able to now visualize the heart. Again, anterior, inferior, posterior, superior, patient's right, patient's left, liver is a window. You've got right ventricle, left atrium, right atrium. And you're going to be looking here for the presence of any fluid in the pericardial sac surrounding the heart. It's important to remember that any structure close to the diaphragm is going to be sensitive to the effect of respiration, whether positive or negative. If you were scanning a patient, you had adequate depth, you followed the inferior vena cava into the chest, and you're still unable to visualize the heart, have the patient take in a deep breath. Here we followed the inferior vena cava into the chest, and we're unable to see the heart. By having the patient take in a deep breath, we go from seeing pretty much nothing to now having a good 4-chamber view of the heart. So make sure that you remember to do this. If you don't get the image you want and you've got all the other settings correct, have the patient take in a deep breath and see what happens. Now here we have a synchronized video that will just put all of this together for you. So again, you start off in an AP plane, anterior, posterior, right, left, and here you've got the inferior vena cava. And you can see as we angle in, you're following the inferior vena cava until you get the view of the heart that you want. This now concludes the subcostal performance video. Welcome to the eFast Exam Parasternal Long Axis Performance Mastery video. I'm Dr. Robert Jones from Metro Health Medical Center in Cleveland, Ohio. In this video, we will describe indications for performing the parasternal long axis window in the trauma patient. We'll describe sonographic techniques for performing the parasternal long axis window. We will discuss pearls and pitfalls of this window. And by the end of this video, the learner should be able to demonstrate the parasternal long axis window on a normal subject. So what are the reasons to perform a parasternal long axis window in the trauma patient? This window for most emergency physicians or trauma surgeons is not the primary window used to obtain visualization of the heart for the detection of hemopericardium. Usually this window is performed because there was inability to perform the subcostal window. This may be due to a patient with an obese abdomen, or may be due to the fact that the patient had a penetrating or blunt injury to the subxiphoid space that made them intolerant to transducer pressure for the sonographic exam. It may also be due to the fact that on the subcostal window, the provider could not differentiate an epicardial fat pad from a pericardial effusion, and lastly, it may be due to the fact that the provider could not differentiate between a left pleural effusion and a pericardial effusion. Let's begin by gaining an understanding of what the parasternal long axis window is. In order to perform this window, you're going to need to understand how to access the heart using a transthoracic approach. The parasternal long axis window is essentially a long axis cut through the heart with an imaging plane that extends from the right shoulder to the left hip. If we simulate the presence of a sternum and ribs, you can see that access to the heart for imaging is going to be rather limited. This is why it's important to use a transducer with a small footprint. To perform the parasternal long axis window, you're going to place the transducer on the anterior chest just to the patient's left of the sternum at about the level of the third or fourth intercostal spaces, with an imaging plane that goes from the right shoulder to the left hip. If we look at this three-dimensional reconstruction of the heart, you can see that as we make the cut of the parasternal long axis window, this is the image that's going to be provided. We'll rotate it here. And what you'll end up with here is the right ventricular outflow tract, the left ventricle, left atrium, aortic outflow tract, and here's the descending aorta here. This area here is going to represent the left pleural space. So from an orientation standpoint, this is going to be anterior, this will be posterior, this will be the direction of the feet, and this will be the direction of the head. Let's compare the anatomic slice with the ultrasound image. So again, orientation, anterior, posterior, foot, head. We'll explain in a little bit why this is the orientation for the parasternal long axis window. But here you can see left ventricle here. You can see left ventricle here. Here's the interventricular septum. Here's the posterior wall of the left ventricle. You can see here's descending aorta. Here's descending aorta. Here you have the left atrium and mitral valve. Here you have the left atrium. Here you have the aortic valve and then the aortic outflow tract. And here you have the aortic outflow tract here. And here you have the right ventricular outflow tract. Let's take a look now at scanning essentials. The first thing we'll look at is transducer selection. When we talked about subcostal window, we also included a large footprinted curvilinear transducer. I have taken that out here since the ability to scan transthoracically between the ribs is not effectively done with a large footprinted transducer. From a frequency standpoint, in an average adult, you will need somewhere between 2 to 5 megahertz in order to provide adequate penetration, and I would recommend either a small footprinted curvilinear, which is what you see here, or a phased array transducer to perform this exam based on the limited scanning window. From a patient positioning standpoint, again, most trauma patients are going to be in a supine position, so that is where you should start, and in a lot of patients, this will be completely adequate. However, in some patients, the left lateral decubitus position may improve image quality by opening up the window. However, the ability to do that would be based on the clinical circumstance. Frequently, the immobilized or ventilated patient cannot easily be repositioned outside of the supine position. And these are things that have to be taken into consideration when performing this window. Let's take a look at image orientation since there's a lot of controversy. We're going to go ahead and assume that you're in the abdominal preset. If you take a look, this image here is reversed from this image here. This is a traditional cardiac orientation where you have the following orientation: anterior, posterior. To the left of the screen, you have the foot. To the right of the screen, you have the head. In the normal orientation that we're used to for abdominal scanning, you would expect, like you would see here, anterior, posterior, head, and foot. The problem is that cardiologists have a different imaging orientation. When they scan in the long axis, they have it set this way so that the caudal direction or the foot is to the left of the screen and the head is to the right. And this is the image you're going to get for the parasternal long axis. You'll have right ventricular outflow tract, interventricular septum, left ventricle, posterior wall of the left ventricle, descending aorta, left atrium, mitral valve, aortic valve, and aortic outflow tract. Here, it's just flipped. You've got right ventricular outflow tract, left ventricle, aortic outflow tract here. You've got mitral valve here, and you've got left atrium, and here you have descending aorta. So which image orientation should you use? In the rest of this module, we're going to be using the cardiac orientation. So to obtain this using an abdominal mode, you're going to place the transducer indicator toward the patient's left hip in order to obtain this. If you're at a center that uses the emergency medicine orientation for the parasternal long axis window, then go ahead and continue to do that. I just think it's easier to use the cardiac orientation since that's what your consultants will recognize, and that's what you're going to find when you review cardiac textbooks. Let's just review this one more time so that there'll be no confusion. Here we're scanning in the abdominal mode, but we're obtaining cardiac orientation. So the transducer is placed in either the third or fourth intercostal spaces with an imaging plane going from right shoulder to left hip. The transducer indicator should be directed towards the patient's left hip, and you can see the indicator dot here. So you've got anterior, posterior, foot, and head. Therefore, you've got right ventricle, interventricular septum, left ventricle, left atrium, mitral valve, aortic outflow tract, descending aorta, and this patient does have a small pericardial effusion along the back wall here, as well as anteriorly. Let's go ahead and sum things up and review a real-time video clip. So again, for transducer placement, you're on the anterior chest wall to the patient's left of the sternum, imaging plane right shoulder to left hip, indicator to the patient's left hip while in the abdominal mode, and that will give you this image. So you can see here, you got right ventricular outflow tract. You can see the nice squeeze in this heart between systole and diastole. You've got the left ventricle here. You can see the nice normal opening of the anterior leaflet here, the mitral valve. You can see the left atrium. You can see the aortic valve opening and closing. You can see the aortic outflow tract. Here you can see the descending aorta. And this is the left pleural space here. And you can see the ring downs or comet tails from air within the lung. If there was a pleural effusion, you would see it in this area right here. Let's look at some reasons as to why you may not be able to visualize the heart when attempting a parasternal long axis window. First, patients who have emphysema or COPD have hyperinflated lungs. The lungs tend to encroach on the potential imaging window, making it more difficult to obtain the parasternal long axis window. In these patients, it may be beneficial to try turning them on their left side to see if that provides a window, but that still may be unsuccessful in these patients. In a patient who has a penetrating injury to his or her chest wall, they may have subcutaneous emphysema, which will prevent visualizing deeper structures. If you're able to move the transducer and get away from the subcutaneous air, that may be helpful, but in patients that have widespread subcutaneous emphysema, it would be unrealistic that you're going to be able to visualize the parasternal long axis window. Patients who are morbidly obese may be easy to scan using this window. However, they frequently may be a challenge. Again, if you're unable to visualize with the patient supine, I would recommend attempting turning the patient, if clinically possible, into the left lateral decubitus position. This concludes the parasternal long axis performance mastery video. Go ahead now and watch the parasternal long axis interpretive mastery video.